characteristics of Klebsiella ozaina. Klebsiella ozaina is primarily a colonizer of the oral and nasopharyngeal mucosa and has been a known cause of chronic inflammatory disease of the upper respiratory tract. K. ozaina is a gram-negative, non-motile aerobic and encapsulated rod bacterium. It is distinguished from K. pneumoniae, subspecies pneumoniae, by a negative reaction to Vogus, Proskauer, and malonate tests. K. ozaina is an unusual human pathogen and rarely causes serious infections. Klebsiella are among the most frequent pathogens responsible for a wide range of community and hospital-acquired illnesses. The reason why Klebsiella is accountable for a variety of community and hospital-acquired illnesses is because most of the people affected by this disease are the people with weak immune system and individuals who are hospitalized for a long period of time. K. pneumoniae is a significant emerging pathogen in community-acquired liver abscess around the world, particularly in Taiwan, Asia, and the United States. So the first case of K. pneumoniae was reported in Taiwan in 1986, and since then it has spread to other Asian countries such as Hong Kong, Malaysia, and Singapore, and now rapidly spreading in the US and around the world. Predisposing factors for K. pneumoniae infections include old age, chronic respiratory disease, diabetes, or alcoholism. The organism is carried in the respiratory tract of approximately 10% of healthy humans, making them susceptible to pneumonia if the host defenses are compromised.
We'll talk about the pathogenesis and spectrum of disease for Klebsiella pneumoniae. K. pneumoniae is most likely to be a primary, non-opportunistic pathogen. Although this organism is a primary pathogen, patients with K. pneumonia infections frequently have advanced age, chronic respiratory disease, diabetes, or alcoholism. Members of the genus Klebsiella pneumoniae usually have prominent capsules composed of complex acidic polysaccharides. Capsules appear essential to the virulence of Klebsiella. The first is K1 capsule. It is an important virulence factor for K. pneumoniae liver abscess. And the second one is the K2 capsular serotype. For example, may be less virulent than others.
Okay, so good evening, everyone. So we are now down to our laboratory diagnosis for Klebsiella pneumoniae, subspecies Ozoniae. So its specimens are nasal secretion and cerebral abscesses. For nasal secretion, the container is a swab moistened with Swartz or Amis medium. Transportation within 24 hours. Storage before processing is also within 24 hours. And for cerebral abscesses, its container is a sterile screw cup tube. The patient preparation, we need to disinfect first the skin before aspirating the specimen. And it needs to be immediately transported to the laboratory. And for storage before processing, it's within 6 hours in a 37 degrees Celsius temperature. For the specimen processing, so the transport temperature is room temperature. Specimen stability is at room temperature for 24 hours. And the rejection criteria is R, improperly labeled or identified specimen, improper swab type received, expiration collection or device or swab, grossly contaminated specimen, and delay in transport or transport at the wrong temperature. So the direct detection methods for Klebsiella pneumoniae subspecies ozoniae are nutrient agar, tryptic casensoy agar, purple lactose agar, blood agar, and differential plating media for Enterobacteriaceae, which are Kirgalsky agar, McConkey agar, using methylene blue agar, and bromothymol agar. So for the cultivation of the bacteria, colonies become visible on non-selective and differential media after 18 to 24 hours of incubation. Non-selective media such as SBA and chocolate agar, as well as selective media such as MAC to recover enteric organisms from wounds, respiratory tract, secretions, urine, and sterile body fluids. Chocolate agar or SBA plates, enteric bacteria produce large, grayish, smooth colonies. SBA colonies may be beta-hemolytic or non-hemolytic. For the approach to identification for Klebsiella, K. pneumoniae subspecies ozoniae has been isolated from nasal secretions and cerebral abscesses. These organisms causes atrophic rhinitis, a tissue-destructive disease restricted to the nose. It is highly associated with the presence of plasmid-mediated extended-spectrum beta-lactamase, contributing to the large number of antimicrobial-resistant hospital-acquired infections seen today. Klebsiella are readily isolated and identified in the laboratory. These organisms usually ferment lactose, although the subspecies Ozoniae are non-fermenters and are indole-negative. Hypervirulence Klebsiella pneumoniae or HVKP usually possess a hypermucoviscous phenotype, although the sensitivity and specificity of the string test is less than optimal. A better diagnostic test for HVKP is needed. For the serodiagnosis, it's R, passive hemagglutation test, enzyme-linked immunosorbent assay, and Widal test.
Antimicrobial susceptibility testing. Klebsiella pneumoniae is susceptible to these antimicrobial drugs, namely cephalothene, amikacin, kanamycin, tetracycline, and cefotaxime. To prevent the spread of infections, patients should also clean their hands very often, including before preparing or eating food, before touching their eyes, nose, or mouth, before and after changing wound dressings or bandages, after using the restroom, after blowing their nose, coughing, or sneezing, and after touching hospital surfaces such as bed, rails, bedside tables, doorknobs, remote controls, or the phone. Safety is inexpensive, but it is priceless. Thank you everyone for listening. God bless.